you very much, Mr. Chairman, for this nice introduction. Thank you very much, Gary. Yesterday they caught the silver thief in the United States. Is he working for you? All right, let's just talk about autoimmune diseases. This is a field which I always was surprised is hardly to find in anti-aging conferences, but it's a typical aging disease. And so that's why I decided to go deeper into this field and to show you something how you can even treat this. And I do it since some years with hormone replacement therapy. Autoimmune disorders, just to give you a short overview, are a device group of conditions which occur due to an abnormal stimulation and signaling within the immune system. Self versus non-self recognition is altered. We have a lot of examples of autoimmune diseases. As you can see, that many body parts can be actually affected, from the brain, the gut especially, from the bone, marrow of the bone itself, the joints, and so on. So everybody of you will have seen one or two patients with autoimmune disease minimum, if not many more. Because you see the distribution, there's the incidence, if you see, is a lot of autoimmune diseases, but it's very sex differentiated. You know, there's some very much, mostly are female are affected in diabetes, mellitus, and myocarditis, and ulcerative colitis. As well, but mostly female, so it's typical. That gives you probably an idea which hormone is involved in this when we talk about female. It's a genetic connection. Yes, there is a genetic connections. We have to find out that there is the so-called major histocompatibility complex. The MHC gene is involved in this, and people respond different to immune problems. Just a short overview, what is the immune doing? We have, the extracellular allergen, antigen, the intracellular bacterial antigen driven. So it's going up to at least to an antigen presenting cell, which meets as the T helper cells, and the T helper cells have the surface marker of CD4. And these T helper cells, they differentiate in cells like TH1, T helper cells 1 or 2, depending on which cytokines are produced and which cytokines are guiding this. So it's a guiding stuff like in stem cells that we heard today, which guides what? And interferon gamma is a very important one, like TNF-alpha, interleukin 1, while the TH2 is more anti-inflammatory cytokines involved, more, but not only. And then we have the B-cell activation as well, with this finally going into allergies and memory. Helper T cells are found in two distant cell types, as I told you, TH1 and TH2, distinguished by cytokines. This is the most important message. And then once it's done, it comes to an autoimmune progression, depending on which of the cytokines, the TH1 cytokines or TH2 cytokines, are more in the dominance. The characteristics of cytokines is that there are small proteins that they are similar to hormones. They are messengers and growth factors and control the immune system. If we see, this is a picture of cytokine network. You see, this is a big cytokine network which is included in the bone marrow, but in the immune system, but as well in the stem cell activation. As you heard, we need cytokines to get the stem cells activated. So how does it work? We have the CD4 T cells, we have the antigen which gives the activity and the maturing to the TH1, TH2 again, then they are so-called effector cells. We have the pro-inflammatory cytokines, especially like interferon gamma, interleukin 2, leukotrienes, and we have the anti-inflammatory IL-4, IL-5, IL-12, and so on. And this is mostly then going into the cellular immunity, and this was going into the humoral immunity with immunopathology, atopic diseases. So actually there's a yin and yang of TH1 and TH2. And if you want to treat a patient with autoimmune diseases, you have to see which one or which substance is working on TH1 and TH2, and there belong hormones, there belong natural substances, there are peptides, whatever is going on. And in the moment you know how to do this, and you know what you have to avoid if you are dealing with hormone replacement therapy, because in some cases you can just create an autoimmune disease. So we have the B cells as well, and T cells, they have a connection and communication with each other as well by cytokines. That is very important to know. They can inhibit them and can stimulate them. So the function is the cytokines secreted by TH1 can activate and attract macrophages to the inflammatory action. This is what they should do. Interferon gamma inhibits the polarization of TH2. So in the moment, TH2 is the one which is it protects us from infection. Is the pro-inflammatory or inflammatory response, TH1. TH2 is the anti-inflammatory response, which does not protect us, but makes more problem, especially as when we age, we are going to the TH2 more than to TH1, and that's one of the reasons. Most people die by infections, not by hormone deficiency, not by whatever, most by infections, because they have no defense anymore. So in the immune response, both subsets activated in the lymph nodes, immune responses, they make immune responses to complex antigens. TH1 cells leave the lymph node to find activated endothelium tissue to activate the macrophages. TH2 cells can stay in the lymph node to activate the B cells. There's more than to say. This is the primary CD4 cell, the non-activated, the naive cells, and they can differentiate it in so-called TH7 cells, which are going to extracellular bacteria, fungi, autoimmunity as well involved, TH1, which we saw, defense, TH2, and regulatory cells. And you see different cytokines are involved in this. And what can they do if the TH17 is more activated? Be prepared for a wreck. If you want to give more stuff on the speed, so you activate the TH1. If you want to break down, you activate the TH2, or you have the yellow light, which gives you a sec. Be prepared to slow down. So whatever you do, as cytokines are very, very much dependent on your on the hormonal status of the patients. Whatever you do, you can go this way, this way, this way. But you have to know what you do. This is the most important part. Again, the actions, and the interleukin-2 is a very important cytokine for the activation of CD4 cells, and therefore it's very important as well. It is autocrine activated. Paracrine action you find by the T cells when they go with the B cells, and endocrine as well you find that the cytokines go into the circulation, and this is what we call as general inflammation. So there's never really a located inflammation. The TH1, TH2 antagonism, you can see as well as the interleukin-4, interleukin-12 can block TH1. This is anti-inflammatory, while interferon gamma can block the TH2 cells. So if you increase interferon gamma, you decrease the TH2 and you switch to TH1, you can revival the situation. In healthy individuals, we have normally a balance. This is what we should achieve, a balance between TH1 and TH2. Why in TH2, the imbalance makes a reduced defense against infectious diseases and increase the risk for cancer and allergies. While the TH1 imbalance is increased autoactivity. For example, a woman in a pregnancy, if she would have TH1 dominance, she would lose a baby. This is what we measure in women with high risk of abortions. They lose their kids because they have a high autoimmunity. They have high defense against the own child. So there are hormones involved like estrogen and progesterone, which makes the woman capable to keep the baby not lost. This is a very important point. So bring back, even in pregnancy, this balance, you would make a risk for that. So insulin-dependent diabetes mellitus is a typical TH1. Rheumatoid arthritis is TH1. Helicobacter is TH1. TH2 typical is systemic lupus erythematosus. That's why we treat systemic lupus erythematosus with high doses of DHEA, because DHEA is a hormone which works on TH1. So we switch the TH2 to TH1 and we can treat it. And methyl iron-induced autoimmune diseases as well are mostly like mercury-induced diseases are mostly TH2. Rheumatic disease, for example, if you see here that, rheumatic disease, I got the wrong one, okay. Here you see, this is the same situation, rheumatic disease. You have the TH1 and TH2 situation, and mostly this is turning in a TH1 then, with the pro-inflammatory cytokines, TNF-alpha, interleukin-1, interleukin-6, 17, and at the end, a loss of cartilage. Here you see systemic lupus erythematosus. So DHEA is a very good treatment. If you give high doses of estrogen, what you do is you bring this woman in a very difficult situation. You worsen the situation. So a woman with lupus erythematosus is a contraindication for high dosage. Why low dose of estrogen can do the opposite, can bring her into TH1. MS is another, very important autoimmune disease where you find this interleukin-2, interleukin-6 increased. And you see, depending on TH1 and TH2, you have a disease or you have a remission. So you just put this one into this one and you have the point, or you this one into this one, and you have this disease in control. So a treatment, especially in MS, which is usable treatment, is an anti-TH1 disease. It's a TH1 disease, so you need an anti-TH1 cytokine therapy or an anti-TH2 cytokine therapy. That depends what you measure. You can measure TH1 and TH2 very easily, the amount of cytokines, and you can see which is your patient right now driven. And then you have to balance it. So in pancreas, it's insulin as well, TH1. You have the TH1 cells, and large amount of interferon gamma are produced. So you have to do something which increases this disease to TH2. If you give in insulin, autoimmune insulin estrogens, you can increase, or testosterone, increase the situation and worsen it. So in multiple sclerosis, sometimes they inject interferon gamma, monoclonal antibody. If it's TH2, that can turn TH2 to TH1. Then cytokines, L4 and L10, anti-inflammatory cytokines increase to prevent depression, diabetes. A further major link is oxidative stress, as all these inflammatory situations produce a lot of free radicals. We have to go in this as well and reduce the oxidative stress. If the patient has a depletion of glutathione, from the antigen-presenting cells in vivo, this results in lower TH1 activity and higher TH2 activity. And which does a glutathione depression? Mercury, for example. Okay, the typical TH2 is downstream of the antigen-presented cells going to the B cells. They inhibit TH1 proliferation, inhibit L1 and TNF-alpha, and other cytokines. So they inhibit as well matrix metalproteinase, which is good because on the other side you don't have this problem with the damage of the tissue. This is what I told you, mercury exposure, this predisposes the dominance and autoimmunity, going to more the TH2, and is implicated disease as multiple sclerosis, in some cases and Parkinson's disease. Only few disorders feature TH2 overactivation. Allergen-reactive TH2 cells are thought to be primarily involved in triggering type 1 hypersensitivity disorders, like high fever, urticaria, and so on. In addition, TH2 cell cytokines predominance has been hypothesized in chronic graft versus host disease, which for stem cell situation is very important, stem cell transplant. Progressive systemic sclerosis and SLE. So what do the hormones do? First, number one, melatonin. Melatonin provides a homeostatic situation between the brain and the immune system. It has specific high affinity binding sites on both TH1 and TH2 helper cells, so it balances out very good. Melatonin does not have receptors on B cells, so it's more going to TH1, but it balances very good out. You see, when it's this melatonin here in the daytime, and you see how the switching is of TH1 and TH2, when people feel better with autoimmune disease during the day, that depends very much on melatonin as well. Sexual steroids, estrogens influence the development of antigen-presenting cells. Androgens cause diminished release of hypopodic progenitor cells. And estrogens are part of the histamine secretion. That's very important because this is a typical response from the mast cells. Steroid hormone and immune modulation is done with, here you see, for typical in the pregnancy. The pregnancy is going to a TH2, because the pregnancy needs to be adapted to the fetus and not to get aggressive against the fetus and get an abortion. While the rheumatoid arthritis is TH1, and if you see the estrogen, pregnancy has high progesterone, high estrogen, and the other situation is low estrogen. Estrogens influence the development of the immune-competent cells. A part of the histamine secretion, as I told you, and suppress NF-kappa B, the transcription factor for inflammation. You see that during the cycle, which is, I think, very important. If you have here the estrogen, ovulation, progesterone, and the T cell number increases during the ovulation, goes down in the second phase. But if you see the predominance of TH1 or TH2, you see that red is TH1 and blue is TH2. It's going in the ovulation, pre-ovulation, and ovulation first goes into TH2. This is the nature provides the body with probably pregnancy. So that's why they say, okay, when you got pregnant, I have to be aware. If the pregnancy does not happen, TH2 goes down and TH1 goes again up. So in women, during the cycle, it's very much the effect. The same in the menopause. In the menopause, it's different at the end, but because with increasing age, we lose the immune cells and the activity, and it's going more in the TH2 pathway after the menopause. Estriol as a hormone involved in immune changes is very important. Estriol has good effects on immune-related disease like multiple sclerosis, and you can treat multiple sclerosis with estriol. And here you see the difference with low estrogen and high estrogen. Progesterone, testosterone more goes to the TH2. So if you give high estrogen, you increase much the TH2 situation. Lower the estrogen, very low estrogen. And we know from our study that low estrogen treatment in a low dose has the same effect like high dose. That's why the typical pharma preparation is actually a high dose estrogen. A compound pharmacy preparation mostly is low dose. So there's a new role for sex hormone in treatment of autoimmune diseases, and not only cortisol, like cortisol is always used for this to suppress TH1 and lead the cells in TH2, the usual one, or interferon gamma, but now we can use actually estrogen, testosterone in many cases. The main thing is that you measure your patient before, which is, the disease, but some diseases have, like maculage. So you need to measure first, is it more in the TH1 or more in the TH2? Progesterone as well, the pregnancy. And you see as well, this picture shows very good. Testosterone increases interferon gamma as TH1 into TH1. And at the end of the day, we can work with this very nicely. Cortisol and DHA, as we know, they have different effects. You know, cortisol from ACTH goes via the monocyte interleukin 12 and leads the cell to TH2, while the normally differentiation is to TH1. If DHA is low, and this is when we age, we have a higher breast cancer risk, and we have a higher risk for lupus erythematosus and so on. So we give DHA, we can lower the cortisol by, or balance the cortisol, and we have a better TH1 situation. Actually, this is probably one of the reasons why breast cancer is increased in the breast. As we know, local synthesis of estrogen is a problem, and not the serum level is more in the breast, in the fat tissue, and the aromatase can very much activate it by stress. This one, you know, the metabolic product of estrogen, but as well from TH2. TH2 situation increases the aromatase and increases estrone situation, which can lead to improved cancer. Thank you very much. I may stress on this that tomorrow Dr. Nestri will talk here about a very interesting thing about adipose-derived cells. Thank you very much for your attention.
Thank you for your timing too. Any questions from the floor? May I ask you, in my experience, which is much less than yours, there's a fairly close relationship between immune response and the autonomic nervous system. And I mention this particularly with the speaker following on, that you can do an awful lot to improve autonomic function and immune responses. Would you not include that in your approach to this?
Absolutely, absolutely. That's why, actually, hormone treatment should always include this, for my opinion, because I always try to measure as well the neurotransmitters, in which way they are working, and so for. I think it's a part of every hormone treatment, every immune treatment. The balance, I mean it's the same, yin and yang, TH1, TH2, sympathicus and parasympathicus. I think it's really the same.
Right. Thank you very much.
Thank you very much.
Thank you.